All right, welcome back for the third session. Our third topic for the session today is going to be pharmacokinetics, and our speaker for this session is Dr. Curtis Smith. He is a full professor at Ferris State University in Lansing, Michigan. Dr. Smith received his bachelor's degree from Ferris State University and then completed his Pharm.D degree at the Medical University of South Carolina. After completing a fellowship in pharmacokinetics and pharmacodynamics at the University of Oklahoma, he returned to Ferris State University, where he's now a faculty member. He practices in the area of pharmacokinetics and special populations, in internal medicine, infectious disease, and surgery and trauma. Dr. Smith has served as a faculty member for the ACCP Updates in Therapeutics prep course since 2002. So, Dr. Smith.
Thank you. Good afternoon. For the last session of the day, I commend all of you who stuck it out the entire day, one more hour. It's also the last chapter in Book 1, so we're at the very end of Book 1, and then tomorrow morning when I speak on infectious diseases at 9 in the morning, we'll start on Book 2. So I have no conflicts of interest regarding the material that I'll be presenting today. And here are your objectives, which are in the book, and just for time purposes, I'll skip through these, but you can look through them. I am going to go over the various areas that we're going to cover during the next hour in regards to pharmacokinetics. And here they are here. We're going to start out talking about some basic pharmacokinetic relationships. This is basic things that you learned probably in your second year of pharmacy school. We'll go over things that are specifically related to ADME, absorption, distribution, metabolism, and excretion. Talk a little bit about nonlinear pharmacokinetics and non-compartmental pharmacokinetics. Talk some about data collection and analysis, which is very important when it comes to pharmacokinetics. Then I'll speak about pharmacokinetics in special populations, specifically patients with renal disease and hepatic disease. And then finally, a very little bit on pharmacodynamics, just as a little refresher in case those sorts of questions come up on the exam in the fall. There is a table of pharmacokinetic terms on page 494 of the handout, so if you're wondering what the term means, you can go there, and there's a whole table, and it has each of the terms listed there. And for all of my slides this afternoon and tomorrow morning, what you'll notice is at the bottom of the slide will be a number. That's the page number of this particular book. It doesn't have the 1 in front of it, but it's for Book 1, obviously. And then if it's a question, if it's one of the assessment questions, the page where the answer is will be in parentheses next to the number where the question is. So as you can see here, this question is on the top of page 472, and then the answer, if you want to look at that, is on 496. And you can also make sure that you have your cards out and available, and when I go through the question, you can put the card up so I can sort of get a little feel for how you're moving through this particular material. The first few have a lot to do with calculations, so I understand if you don't have a calculator in front of you, obviously it's going to be a little more difficult, but some of them you can think through in your head as well. So the first question is HR. HR is receiving vancomycin for an MRSA bacteremia. HR has chronic renal failure, and he is given a 1 gram dose on March 21st at 12. And then 2 hours later, a concentration is taken, which is 23.8 milligrams per liter. And then no other doses are given, but a concentration is taken 3 days later, which is 12.1 milligrams per liter. And the goal is to keep the patient at a trough concentration, or let the patient go no lower than 10 to 15 milligrams per liter. So if you were to give a dose at 4 p.m. on March 24th, and your goal trough concentration was 10 to 15, and we can assume we're giving another 1 gram dose, which would represent the best time to give the next dose. So we're giving a 1 gram dose on March 24th at 1600, and when would you need to give the next dose? In other words, to make sure that the concentration doesn't go below 10 to 15. 1 day after the dose on the 24th, 3 days from the dose on the 24th, 6 days from the dose on the 24th, or there is insufficient information to calculate when to redose. So think about that. We have some colors coming up. Okay, so let's think this through a little bit. If you weren't a fan of pharmacokinetics or math, this is going to be very painful, but if you were, you'll really be geeked about this. I like pharmacokinetics, I like math, and so this is always very interesting to me. For other people, it's just terror. Here's an equation that you all should already know, and if not, you should refresh yourself with. Volume of distribution is equal to dose over change in concentration. If it's the first dose, it would be CP0. But in general, volume of distribution is equal to dose over concentration, and this can be manipulated in any way that you want. So change in concentration is equal to dose divided by volume of distribution, or dose is equal to change in concentration times volume of distribution. So it's a very functional equation that I'm sure you all remember. So we can calculate the volume of distribution by knowing that we gave this patient a gram dose. His concentration went up to about 23.8. So his volume of distribution is about 42 liters using this equation. We can also calculate his elimination rate constant, or K. Again, that's something that I'm sure you're all familiar with. Elimination rate constant is equal to the difference in the two concentrations over the change in time. So change in concentration over change in time. We had two concentrations without a dose in between them, and therefore two times, obviously. So we can use this equation to calculate K. And just as a refresher, half-life then is equal to 0.693 divided by K. So this patient's K is 0.0094 because we took the natural log of each of the concentrations, subtracted them from each other, and then divided by the change in time, which was 72 hours. So when we give another dose to this patient, we give another 1 gram dose, the volume is going to be the same as it was before. So we give that 1 gram dose, we know it's going to go up by 23.8 milligrams per liter. Now, this second dose, however, is different than the first dose because in the first dose, the patient didn't have any vancomycin in their system, so we started at 0, it went up 23.8. But this time, we started at 12. We already had a concentration at that point. So now the concentration after the second dose is not going to be 23.8, it's going to be 36 because we started at 12. So now we're moving from 36 instead of 24, which is where we were before. And then you can use the equation CP0 or C is equal to CP0 times e to the minus KT, and we figure out that the answer is about 6 days. And I tried to make this particular example such that you could almost do it in your head if you could figure all these things out. So going from 36 to 18 is 1 half-life, and then 18 to 9, and that's about where we wanted, the lowest that we wanted to get would be another half-life, and we knew that the half-life from before was about 3 days, so that would be a total of 6 days. So the correct answer is C, 6 days from the dose on the 24th. And from here, I just want to refresh you with those basic pharmacokinetic equations that I went through. All right, another basic pharmacokinetic equation. This is question 2 on page 472. Following administration of 100 milligrams of a drug IV and 200 milligrams of the same drug orally, the AUCs are 50 for the IV drug and 25 for the oral drug. So what is the bioavailability of this drug? Get some brave people. So when you're calculating a bioavailability, it's the dose given IV times the AUC given extravascularly, so that could be IM, sub-Q, oral, rectally, whatever, just non-IV dose, over the dose given extravascularly times the AUC IV. So what we'll have is 100 times, I've got to remember my numbers here, 100 times 25 over 200 times 50. And when you do that, then the answer is 25%. So the correct answer is A. And then the last initial question, again, number 3 on page 472, is about LB. LB is receiving tobramycin for Pseudomonas aeruginosa pneumonia. LB has chronic renal failure as well. A loading dose of 160 milligrams is given at noon over 1 hour, and then the concentration at 1800 hours, so 5 hours after the end of the infusion, is 6.5, and then the concentration 12 hours later is taken in the morning at 0600 is 5.4. So when LB's concentration is 1, what dose is needed to achieve a peak of 9? 140 milligrams, 160 milligrams, 180 milligrams, or 200 milligrams? And probably most people are not going to guess. This is a little even more complicated than the two before. So let's go through it step by step, though. Again, we use the same elimination rate constant equation where K is equal to change in concentration over change in time. And so we calculate the K as 0.015. And then this equation at the bottom, which is also a very common pharmacokinetic equation used quite commonly. You should remember it from school as well. If not, this is why I'm doing it now as sort of a refresher, where CP0 is equal to C1 divided by e to the minus KT. So we're going backwards, or we're back extrapolated. Before with the vancomycin we were forward extrapolating, but now we're backward extrapolating. That's why you're dividing here. So 6.5 divided by e to the minus KT equals 7. So we know that after we gave that patient 160 milligrams, their initial concentration was 7. And from that previous equation we knew before, volume is equal to dose over that initial concentration. So the dose we gave is 160 milligrams over 7. 7 is that CP0, and so the volume of distribution is about 23 liters. We then know that when the concentration hits 1, in order to get up to 9, we're going to have a change in concentration of 8, going from 1 to 9. And so the dose we need to give is 8. That actually should be times. It says divided there on the screen now. 8 times 22.9. So dose is equal to volume times, or concentration times volume. And so the answer then is 183.2 milligrams. So the correct answer is C. You'd need about 180 milligram dose in order to go from 1 to 9. So a little bit about absorption. We're going to move on now on page 473. I'm going to talk a little bit about some things related to absorption, distribution, and metabolism. So absorption, just two things I want to mention. The first is the first pass effect. That, as I'm sure you're aware, is where blood perfusing the GI tissues passes through the liver. Virtually all the blood from GI tissue passes through the liver, except for a few areas. And then also enterohepatic recirculation, which is on the top of page 474, and that's where drugs can be excreted in the bile. They're excreted usually as metabolites, which allows them to be excreted in the bile. And then normal flora within the GI tract will metabolize the drug and take it from its metabolite back into the parent drug, the active drug, and then that active drug can be reabsorbed. And so I have some examples there on table 1 where that occurs. Estrogens and oral contraceptives is a very common example of that enterohepatic recirculation. So moving on to now question number 4, which is in the middle of page 474, that also has to do with absorption. Which statement best describes P-glycoprotein? First, it is a plasma protein that binds basic drugs. Second, it transfers drugs through the GI mucosa, increasing absorption. C, it diminishes the effect of cytochrome P450-3A4 in the GI mucosa. Or D, it is an efflux pump that decreases GI mucosal absorption. Okay, some answers, not a whole lot. So let's go through a little bit about P-glycoprotein. P-glycoprotein and cytochrome P450-3A4 both act within the GI mucosa, and their role is to prevent us from ingesting or absorbing, I should say, a toxic substance. So if you happen to ingest a toxic substance, their role is to decrease absorption and make sure that doesn't get into the system and doesn't ultimately kill you or harm you in some way. Cytochrome P450-3A4 you're probably aware of, but P-glycoprotein is actually an efflux pump that pumps drug back into the GI lumen. So basically what it's doing is as the drug is trying to be absorbed, from the GI tract. It's a pump that's pumping it back into the GI lumen so it isn't absorbed. So it's sort of a protection from that toxic substances. Most CYP3A4 substrates are also P-glycoprotein substrates. So if you have a substrate that's trying to be absorbed, you have two things that are usually trying to stop it from being absorbed. And many CYP3A4 inhibitors or inducers also do the same thing, inhibit or induce P-glycoprotein. So we have drug interactions where it's not only affecting the liver, but it can also be affecting absorption as well through this mechanism. And some examples of P-glycoprotein inhibitors or inducers are dabigatran, digoxin, HIV protease inhibitors. Those all can be actually, I should have said substrates, those all can be affected by various inhibitors. And I have some examples there on the bottom of page 4 where those agents are affected by various substances, which I also have listed there on 474. So P-glycoprotein, just like CYP3A4, can be an important mechanism as far as drug interactions are concerned. So the answer is D. P-glycoprotein is an efflux pump that decreases GI mucosal absorption. All right, moving on to distribution, and I've already shown you this equation. Volume of distribution is a constant that relates the amount of drug in the body to the observed concentration. And we can calculate the volume of distribution by knowing the dose and the change in concentration. Protein binding also affects distribution within the body, and there's 3 main substances that bind drugs in the body. Those are albumin, alpha-1 acid-glycoprotein, and lipoprotein. And albumin by far is the most important protein that binds drugs in the body, primarily acidic drugs, and you can see on table 2 different characteristics of each of those proteins. P-glycoprotein can also affect distribution in many different ways. The most clinically important way is that it can decrease the uptake of drugs into the brain. And so that could especially be important with opioids, where induction of P-glycoprotein by chronic opioid use may actually decrease the opioid effect. Remember, if you're inducing P-glycoprotein, you're speeding up that pump, and the pump is preventing drug from getting into the brain. So just like P-glycoprotein prevents drug from being absorbed in the GI tract, it can prevent drug from getting into the brain, and it's a very important mechanism there. Just a few things on clearance. I have some tables, tables 3 and table 4, which go over some important issues related to clearance. So table 3 just talks about the enzymes that are involved in drug metabolism, and table 4 is a table that goes over drug transport proteins, which can be very important for different drugs and their elimination ultimately. I wanted to spend a little more time, however, on cytochrome P450, and so the next question on the top of page 477, question 5, has to do with cytochrome P450. So a renal transplant patient is receiving cyclosporin, and he is diagnosed with community-acquired pneumonia. So the patient is admitted to the hospital and initiated on ceftriaxone and a macrolide. And a physician asks you to choose the macrolide which will not interact with the patient's cyclosporin. So which of the following would be the least likely to interact with cyclosporin? Erythromycin, clarithromycin, azithromycin, or all macrolides will inhibit CYP3A4? Some answers. Good. Lots of green out there. That's good. So I'm going to talk a little bit about cytochrome P450 and characteristics of cytochrome P450. It's a group of enzymes that are responsible for phase 1 metabolic reactions. And so if you look back on table 3 on page 475, you'll see they were under the oxygenases, and those are phase 1 reactions. They're located throughout the body, primarily in the liver, but there's also, as I just mentioned, cytochrome P450 in the small intestine, and there's also some in the brain, lung, and kidney. Usually drugs will have a high affinity for one particular enzyme, but there are some drugs that utilize other, either other cytochrome P450 enzymes or other secondary pathways for elimination. And I'll talk a little bit about that in a second. There is a table I have at the end of the chapter on 493. I can't say it's totally updated, but it does give you a pretty good feel for different cytochrome P450 drugs. Substrates is one row, and inducers and inhibitors. So if you want to look at that, you can go through that. Obviously, for the exam, you're not going to memorize that table, but it can be used as a reference. So cytochrome P450, the nomenclature has been the same since 1987. In 1987, scientists came together and they said we have to have a common nomenclature. Before that time, people named enzymes whatever they wanted. So now all the enzymes start with CYP, which just means it's a cytochrome P450 enzyme. Then the next number is the family number, followed by the subfamily letter, and then the specific enzyme number. And family, those enzymes that are within the same family are at least 40% identical, and those enzymes that are within the same subfamily are at least 70% identical. So cytochrome P450 2C9 and 2C19 are more than 70% identical. If you look at content of cytochrome P450 enzymes in the liver, you can see the distribution there, and CYP3A4 makes up about 25% of the content of cytochrome P450 in the liver. And then you can see the other enzymes. You can see 2D6, which is a very clinically important cytochrome P450 enzyme, makes up just a small sliver of the total amount in the liver. If we take all of the drugs that are metabolized by cytochrome P450 and then look at the percent of those that are metabolized by each of the various enzymes, we get a little different pie graph. So this is the role of each of the enzymes in cytochrome P450 mediated drug elimination. And you can see that 3A4 still is very, very predominant. So a third of the drugs that are metabolized by CYP enzymes are metabolized by CYP3A4. And you can see that even though 2D6 makes up a small amount of CYP in the liver, it accounts for a large, almost 25% of all the drugs that are metabolized by CYP enzymes are metabolized by CYP2D6. Now, there are some characteristics of cytochrome P450 which I have listed on the bottom of page 478, and if you want some examples of, well, what drugs actually have that particular characteristics, I have examples there. The first characteristic is that inhibition is substrate independent, which means that if a drug inhibits CYP3A4, it will inhibit every drug that is metabolized by CYP3A4. So it doesn't pick and choose which 3A4 substrates it's going to inhibit. It's a general inhibition, so it's going to inhibit all of the CYP3A4 substrates. Now, some substrates are metabolized by more than one CYP P450 enzyme, and you can see that on the table on page 493. Tricyclic antidepressants, SSRIs, are good examples of that. And usually if a drug has those multiple pathways, then drug interactions are not as big a deal. Because if one pathway is inhibited or induced, or specifically more likely inhibited, the other pathway then will take over. And so drug interactions are less an issue. Enantiomers may be metabolized by different CYP450 enzymes. Warfarin is a prime example of that. Where the active warfarin is metabolized by 2C9, and so that's where you see the drug interactions. And differences in inhibition may exist in the same drug class, and the example of that is macrolides. H2 blockers are the same thing. You can't just say H2 blockers are going to have the same CYP effect, or macrolides are going to have the same CYP effect, because that's not the case. And in fact, there are differences there because azithromycin specifically does not affect cytochrome P450 enzymes. And you could argue, well, that's because it's not a macrolide, it's an azolide, which is true. But you can't, the point I'm trying to make is you can't lump categories of drugs and figure they have the same effect on cytochrome P450. Substrates can also be inhibitors, and you can see that in the table. Most inducers and some inhibitors affect more than one enzyme. So if you look at the inducers, they pretty much affect all the enzymes. They induce each of them. And inhibitors, some inhibitors can affect multiple enzymes. And finally, inhibitors may affect different enzymes at different doses. So fluconazole is a prime example of that. Lower doses, especially 200, but sometimes even 100, can affect 2C9, so you can see the interaction with warfarin. But it doesn't really affect 3A4 until you start getting into higher doses of 400, 800, or 1,200 milligrams a day. So the answer then to this particular question with the renal transplant patient is C, azithromycin. All right, starting on page 479 then, I have some information on pharmacogenetics, the definition of which is where more than one genetic variant exists stably within the population. So it has to account for more than 1% of the population, and it's a specific variant, and it's stable. Generally then, when that happens, we can divide the population into poor metabolizers and extensive metabolizers. And you can see a picture of that on page 479. And then there's a clear anti-mode that separates the two populations, which again you can see it with a picture on page 479. CYP3A4 actually has a very diverse, there's a very diverse spread of people that are more rapid or more poor metabolizers, but there's no anti-mode. It's just a bell-shaped curve. And so because of that, there's no really pharmacogenetics related to CYP3A4. The phenotype of pharmacogenetics is the clinical expression of the trait, and in other words, are they a poor or an extensive metabolizer? And then the genotype is the actual genetic composition. And some prime examples of enzymes that follow pharmacogenetics or polymorphic drug metabolism are 2D6, 2C19, 2C9, and N-acetyltransferase. And I have a table there on page 480, table 5, that goes over those pathways. All right, nonlinear pharmacokinetics. So this is question 6. This is CM. CM is a 55-year-old man who is started on phenytoin. After a craniotomy. He started on 200 milligrams a day, and his recent steady state concentration is 6 milligrams per liter. So you're working with a group of clinicians and they want to double his dose because 6 is too low for phenytoin. And so what do you tell them about doubling the dose to 400 milligrams a day? A, his concentration will double since phenytoin clearance is linear above the Km. B, his concentration will more than double since phenytoin clearance is nonlinear above the Km. C, his concentration will not change because phenytoin is an autoinducer and clearance increases with time. Or D, his concentration will increase by only 50% since phenytoin absorption decreases significantly with doses greater than 300 milligrams. Good, all right. Getting a lot of good answers. So let's go over nonlinear elimination. We'll talk a little bit more about phenytoin. So nonlinear pharmacokinetics is where you have a saturation or partial saturation of the elimination pathway. It follows the Michaelis-Menten equation, which I have there, written there. Rate of elimination is equal to Vmax times the concentration over Km plus the concentration. And Km is the value where the drug becomes nonlinear. So virtually every drug follows nonlinear pharmacokinetics. But the Kms for the vast majority of drugs are much higher than the concentrations that we see clinically. However, phenytoin is a drug where we utilize concentrations that are above the Km, the Km for phenytoin being about 3 to 6, somewhere in there. And because we achieve or utilize concentrations in the 10 to 20 range, we are always above the Km, and therefore with phenytoin we're in that non-linearity. So the answer then to this particular question is B. His concentration will more than double since the phenytoin clearance is nonlinear above the Km. And because the Km for phenytoin is about 3 to 5, 3 to 6, we are going to be above, and so there's nonlinear elimination, so doubling the dose will more than double the concentration. Now, phenytoin is not an autoinducer. That's carbamazepine. That's the autoinducer. Phenytoin does, however, have nonlinear absorption, which I sort of alluded to in D, but that doesn't occur until you start getting above doses of 400 milligrams. So anytime you have more than 400 milligrams of phenytoin in a single dose, you need to split those doses so you don't get nonlinear absorption, which actually decreases the absorption of phenytoin. All right, non-compartmental pharmacokinetics. I don't have a question for this, but just a little quick review. Non-compartmental pharmacokinetics is done in many instances when we're doing pharmacokinetic analysis because IDing the correct model or compartmentalizing the data is frequently difficult and unrealistic. It's an easy mathematical equations because linear regression is unnecessary. And it requires less assumptions, less computer programs, etc. So when we do non-compartmental pharmacokinetics, what we do is we calculate two main unknowns, and those are area under the curve and area under the first moment curve. And you can see those equations there. Relatively easy to calculate with any sort of spreadsheet. And then utilizing those two things, area under the curve, area under the first moment curve, you can calculate a mean resonance time, which is MRT. You can calculate a clearance, which is dose over AUC, a volume, which is dose times AUMC over AUC squared. You can calculate a K, which is 1 over the mean resonance time, and also an absorption, or a Ka, or an absorption rate constant, which is 1 over the mean absorption time. So it's a very functional methodology in order to calculate pharmacokinetic parameters. All right, back to something that's maybe a little more clinically relevant. That's data collection and analysis. So this is question 7. Question 7 is in the middle of page 482. This is RK. RK is a 54-year-old woman with a history of diabetes and end-stage renal disease. She's receiving gentamicin for a Pseudomonas pneumonia, and a gentamicin concentration is ordered after dialysis. Which is the best approach for obtaining this post-dialysis sample? Obtain the concentration immediately following hemodialysis. Wait a few hours to obtain the concentration, since the concentration will decrease significantly within the first few hours after hemodialysis. Wait a few hours to obtain the concentration, since the concentration will increase significantly within the first few hours after hemodialysis. Or wait until the next day so that all of the effects of hemodialysis have abated. All right, good. Have some good answers out there. So let's talk about data collection and analysis, which many of these things you might not be familiar with. They're sort of behind-the-scenes things, but whenever we're doing any sort of pharmacokinetic or therapeutic drug monitoring, data collection and analysis are extremely important. We need to make sure that whenever we're sampling a drug, that the timing is such that absorption and distribution are complete. There are some drugs like vancomycin and especially digoxin which have really extended times of distribution, and therefore you want to make sure that that distribution is complete before getting a concentration. And then with dialysis, there's always the issue of redistribution. So with dialysis, you're removing drug from the blood. You're not removing it from the tissue. So when hemodialysis is over, then you do get redistribution where drug from the tissue will redistribute from the tissue into the blood. And so if you wait a few hours after the end of hemodialysis, you'll note the concentrations actually go up, and you need to keep that in mind when you're doing those concentrations. Now, in many sites, our site included, we frequently get the concentrations right at the end of dialysis because it's easily sampled then, and the patient is, still in dialysis and can be easily done, et cetera. Whereas sometimes it's forgotten if you wait a few hours after dialysis is done and the patient is sent back up to the floor, et cetera. Most samples we get are serum samples. Some drugs you have to analyze in whole blood or in plasma, but basically serum is where you take the blood, allow the blood to clot, and then spin it down, and you take the serum from the top of the sample. Plasma is just blood that's not allowed to clot, but you still spin it down and you take the top of the sample. And then whole blood is obviously whole blood, not allowed to clot and not spun down. So the answer here for question 7 would be C, wait a few hours because that concentration will increase significantly within the few hours after hemodialysis. All right, a drug assay is touted as having high specificity but low sensitivity. This means the assay can't distinguish the drug from like products, but it can detect extremely low concentrations. The assay can't distinguish from like products, and it cannot detect very low concentrations. C, the assay can distinguish between like products, and it can also detect very low concentrations. Or D, the assay can distinguish between like products, but it can't detect extremely low concentrations. So high specificity, but low sensitivity. Answer? All right. This is also in one of those sort of stats categories, so if you're not familiar with these things, review them because they love these questions. So, assay terminology. Assay terminology, when we talk about an assay, we usually use the terms precision and accuracy. So, precision is reproducibility. In other words, if you take a sample and you analyze it 20 times, you should get the same result every time. So it might not be the correct result, but it should be the same result. So let's say you have a sample that has 10 milligrams per liter and you analyze it and the result is 20 milligrams per liter. Well, we know that's not accurate, but if you analyze then that sample 19 more times, if it was 20 every time, if the result was 20 every time, then that's a very reproducible assay. That's a precise assay. It's giving you the same result every time. And the values that we use to analyze precision are standard deviation and coefficient of variation. So you want low standard deviations, low coefficient of variation. Now, accuracy is just like it sounds. It's accurate. So in other words, if there's 10 milligrams per liter in the sample, when you analyze it, the result is 10. That's an accurate result. And what we use to analyze accuracy is the correlation coefficient. So does the sample, does it correlate with does the result correlate with what we know is in that particular sample? Now, predictive performance is also something you'll see quite commonly that also is a measure of accuracy. And unfortunately, the two terms that are calculated in predictive performance are precision and bias, both of which measure accuracy. And this is, someone's messing with your brain here. So precision in predictive performance does not measure precision. It measures accuracy. And the bias also measures accuracy. Both of them do. So predictive performance is commonly used when you're trying to see if a particular assay will measure correctly the amount that's in that particular sample. And I have the values there for precision and bias in predictive performance. So precision is basically, is it close to what it should be? So if it should be 10, is it close to 10? Is it 9.8, 10.2, etc.? And then bias tells you whether it tends to overestimate or underestimate. So you might have an assay that is precise, but it's negatively biased, which means both of which are measuring accuracy, which means it's close to 10, so it's 9.7, 9.8, 9.6, 9.9, 9.7, but it's biased negatively. It's always lower than what it should be. So those are the two values that you'll see in predictive performance. And then sensitivity is the ability to detect very low concentrations or differentiate very low concentrations from zero. So when the concentration is very low, can you tell that there's nothing there versus a small amount of drug there? And then specificity is the ability to differentiate between like products. So the ability to differentiate between gentamicin and tobramycin in the same sample, or between a tricyclic and carbamazepine in the same sample. So if the structures are similar, can the assay differentiate? So the correct answer, high High specificity means it can distinguish from like products. Low sensitivity means it can't detect extremely low concentrations. So the correct answer is D for question 8. Okay, assay methodology, just very quickly, there's a lot of different assays that are used clinically when we measure drugs. Radioimmunoassays are not used much anymore because they have nuclear waste related to them. And most commonly, we use either EMIT or FPIA. FPIA is the most common. It's highly advantageous, very easy to use, very automated. You don't have the waste that's associated with it. So virtually every drug that's analyzed clinically is analyzed via FPIA. In labs, you might, research labs, you might see more HPLC, mass spec, and then older assays include flame photometry and bioassays, which you might see in really, really old aminoglycoside studies. All right, very quickly, population pharmacokinetics. I have some information just squeezed in there on page 484. So population pharmacokinetics is very useful when you have complicated dosing regimens or when you have drug concentrations before steady state or only a few drug concentrations are feasibly obtained. And basically that's looking at pharmacokinetic parameters in the general population and then assuming that your patient is going to be similar to that general population. And then combining specific information from your patient with the information from the general population to come up with the most likely result using Bayesian pharmacokinetics, the most likely result for that particular patient. So we can sort of estimate what a patient's elimination rate constant or volume of distribution is going to be based on the population that they belong to. All right, moving on now to pharmacokinetics in renal disease and pharmacokinetics in hepatic disease. So looking at pharmacokinetic parameters in special populations. So I have two equations there on the bottom of page 484. This is KM. KM is an 80-year-old female. She was admitted for pyelonephritis with sepsis. She has a past medical history of an MI, CHF, hypertension, osteoporosis, rheumatoid arthritis, and a stroke. Her creatinine is 0.92, her albumin 2.9. She's currently on trimethoprim sulfa, lisinopril, digoxin, furosemide, cimetidine, Tylenol, calcium, carvedilol, and carvedilol. All right, so KM's approximate glomerular filtration rate is 10, 30, 60, or 120. And you can probably eliminate a few of those and then make a 50-50 guess, which is what a lot of people are doing. All right, I'll go quickly through that because that's going to, again, require a calculation. Which of KM's drugs may alter serum creatinine concentrations? Lisinopril and digoxin, trimethoprim sulfa and cimetidine, furosemide and calcium, or acetaminophen and carvedilol? All right, we have some brave souls with correct answers. So let's go through some information on pharmacokinetics in renal disease. So in renal disease, obviously, it's very important that we estimate renal function. And we do that by obtaining a creatinine concentration. Creatinine is nice because it's produced around the clock constantly, and it's eliminated solely by the kidneys, primarily by glomerular filtration, although there is some secretion as well. And so ideally, in order to calculate a creatinine clearance, we like to do a 24-hour urine. But as I'm sure you're all aware, getting a 24-hour urine can be difficult at times. Even in the hospital, it can be difficult. So instead, we do things that are quicker and easier, and those are estimates of creatinine clearance. So we have various equations that estimate creatinine clearance, and the one that's most commonly used is Cockcroft and Gault, which is only used in adults, however, and so I've added also some equations for pediatric patients, which are listed there. Now realize that those are estimates of creatinine clearance. Within the past 10 years or so, various investigators have come up with equations for estimating glomerular filtration rate, which is actually what we want to estimate. So creatinine clearance is actually an estimate then of glomerular filtration rate. So when we estimate creatinine clearance, we're doing two estimates. We're estimating creatinine clearance, which is then estimating glomerular filtration. And so equations were developed that estimate GFR, and these are the equations that are recommended for analyzing and assessing a patient's renal function. Now, I do need to tell you that creatinine clearance equations are still recommended for adjusting drugs in patients with renal dysfunction. But estimates of GFR are recommended in analyzing and following patients with following their renal function clinically. So the two equations that are used to estimate GFR are the MDRD equation, and that was the original equation for estimating GFR. The equation I have in the book there is the one that uses the standardized creatinine, and all standardized throughout labs in the U.S. All creatinine is standardized now, the way they assay it. And so the MDRD equation is used primarily. That's probably the one that's used at your institutions. However, MDRD is not very good when you get above 60. So it's very good at estimating GFR when GFR is 60 and below, but above 60 it's not as good. And so the same investigators that came up with MDRD a few years back then came up with CKD-EPI. And CKD-EPI, or the Chronic Kidney Disease Epidemiology Collaboration Equation, is an equation that is a little more difficult if you look at the equations on the bottom of page 486. Even more difficult than MDRD. However, it's better when you get above 60. So now CKD-EPI is good at all GFRs, not just those that are less than 60. There are some factors that influence estimates of creatinine clearance. Disease states can, primarily disease states that affect muscle mass because it's in the muscle where creatinine is produced. But also things that affect the liver, because creatine is produced in the liver, can also affect creatinine. Your diet can. People that are heavy meat eaters or people that are vegetarians can affect their creatinine, because creatinine comes from muscle, meat is muscle. And then finally, there's some drugs that can alter secretion of creatinine in the kidney. And so those are pharmacokinetic interactions, and I've listed some drugs there at the bottom of page 487 that interact with creatinine by blocking its secretion, and therefore elevating creatinine, but not altering renal function. So the elevation in creatinine is not because the patient's renal function is being altered, but instead it's because secretion of the creatinine is being decreased. And you can see there are drugs that do that. Trimethoprim is a very common one. Cimetidine, which people don't use really anymore, but it can also do that. Fibric acid derivatives, and then dronedarone and amiodarone somewhat as well, can also block secretion of creatinine. Now, drug dosing in renal disease, generally loading doses do not need to be altered in renal disease because all we're doing with loading doses is filling that volume. However, digoxin is a drug that we'll talk about a little later on in the presentation. Digoxin is a drug whose volume of distribution is also affected in renal disease, so its loading dose needs to be adjusted accordingly. And basically, we have to change then the maintenance dose, and that can be either changing the dosing interval or changing the dose. And with different drugs, as I'm sure you're aware, we do different things. Sometimes if you only have very certain drug products that you can utilize, the drug only comes one way, then we have to change the dosing interval. But with other drugs, we can decrease the dose, and with some drugs, we have to ultimately do both, decrease the dosing and decrease the interval. So here's the Cockcroft and Gault equation, as you can see there, that we can calculate for Km. Now that's estimating creatinine clearance, and the question is asking you to estimate GFR. So for GFR, we should be utilizing MDRD. And the equation you can see there for MDRD results in the answer of C for 60 mils per minute per 1.73 meters squared. Cockcroft and Gault, like I have listed there at the top, you can see there that the units are mils per minute, not mils per minute per 1.73 meters squared. So it's not normalized. Cockcroft and Gault is not normalized, whereas MDRD, CKD-EPI are both normalized to a person that is 1.73 meter squared surface area. And then the second question there, which of KM's drugs may alter serum creatinine concentrations? The answer is B, trimethoprim sulfa and cimetidine. Lisinopril may increase creatinines, but digoxin shouldn't. Furosemide may also alter creatinine if you dry someone out, but calcium shouldn't. So the correct answer is B, because trimethoprim blocking the secretion of creatinine and cimetidine can do the same thing. All right, moving on to pharmacokinetics then in hepatic disease. So this is SJ. SJ is a 55-year-old male with fungemia. And past medical history with SJ is that he has hepatic dysfunction. And he now presents with a small amount of ascites, but he is not encephalopathic. He started on caspofungin, and the package insert of caspofungin states that doses should be decreased in patients with a Child-Pugh score of 7 to 9. So, if he has the following characteristics there, what is his Child-Pugh score? So his AST is 85, ALT 56, alk phos of 190, total bili of 1.8, albumin of 2.9, LDH 270, his PT is 14.6, and GGT is 60. So what is his Child-Pugh score? 3, 5, 8, or 11. And Child-Pugh is now becoming much more commonly used. Any new drug has to be assessed for elimination in hepatic disease, and whereas we use creatinine clearances to help us adjust drug doses in renal disease, we use Child-Pugh to help us adjust doses in hepatic disease. So let's go through some rules for dosing in hepatic disease and then Child-Pugh. High extraction ratio drugs are generally affected more from hepatic disease than low extraction ratio drugs. And conjugation, or those phase 2 metabolic processes, are less affected by liver disease. They're generally maintained even as the patient has worse and worse liver disease. So things like oxidation, hydroxylation, etc., those phase 1 reactions will usually go first in liver disease, and then conjugation is one of the last things to go. It's a pretty easy thing for the liver to do. It's one of the last things to go. And so generally when we're dosing drugs in hepatic disease, the recommendation is start low and then increase the dose slowly if you have a measure that you can utilize in order to see if you're giving the patient too much. Let's say you're giving them a narcotic. Well, you can start with lower doses, and then if they need more pain meds, you can go up from there. Now, newer drugs will have recommendations based on Child-Pugh scores, and Child-Pugh looks at 5 liver disease characteristics: encephalopathy, ascites, bilirubin, albumin, and PT. You get 1 point for being normal. So you always should know that everyone has at least a Child-Pugh score of 5. If you're totally normal, your Child-Pugh score is 5. Now, this patient had no encephalopathy, so they get no more points for that. They had a little bit of ascites, so that's 1 more point. Billy was, I've forgotten, but it was 1.8, I think, and so that's another point. So now we're up to 7 points. And albumin was 2.9, and so that's another point. So now we're up to 8 points. And then the PT was not elevated over 4 seconds of control. So overall, then, this patient will have a Child-Pugh score of 8. And that can give you some idea whether you need to adjust or not. And with caspofungin, you do when a Child-Pugh score is 8. All right, pharmacodynamics. So which of the following is a reason for a drug to follow clockwise hysteresis? So this might be something you've never heard of before. Occasionally you'll see a question like this come up, so that's why I wanted to go over it. So which of the following is a reason for clockwise hysteresis? Formation of an active metabolite, delay in equilibrium between the blood and the site of action, tolerance, or an increased sensitivity with time? So when we talk about pharmacodynamics, we usually will, which is the relationship between concentration and response. So remember, pharmacokinetics is basically what the body does to the drug. It absorbs it, distributes it, metabolizes it, excretes it. And then pharmacodynamics is what the drug does to the body, its effect on the body. And in order to mathematically describe that, we use the Hill equation. And you can see that it looks very, very similar to Michaelis-Menten. It's the same sort of equation, but it's using obviously different terms. And then based on the drug's pharmacodynamic qualities, we can develop hysteresis loops. And hysteresis loops are when concentrations late after a dose produce an effect that's different from that produced by the same concentration soon after the dose. So here's a counterclockwise hysteresis. And you see on this particular equation that the y-axis is effect and the x-axis is concentration. And so you can see early after the dose, follow the arrows to know whether you're early or late. Early after the dose, you can see that a relatively high concentration has a small effect. But then if you wait longer, what happens is that same concentration, has a greater effect. So counterclockwise hysteresis is when the concentration will, late after a dose, has an effect that is greater than it does soon after the dose. And so some examples of this are increased sensitivity, formation of an active metabolite, which you could understand. So the concentration of the parent drug is going down, but the active metabolite is going up, causing the effect. A delay in equilibrium between plasma concentrations and the concentration at the site of action. And one example of that is digoxin. If you take a concentration really early after giving a dose of digoxin, the concentration will be such where you won't see much of an effect. But that same concentration later on, if it was to occur once the drug is distributed, would have much greater effect. And so that would be counterclockwise hysteresis. Now, clockwise hysteresis is just the opposite. So this is where the effect soon after the dose is higher than the effect with the same concentration later on after the dose. And some examples of clockwise hysteresis include tolerance, where the patient becomes tolerant over time. So you could think of narcotics or opioids in that way. So concentrations are soon after you take one might have a greater effect than the same concentration much later once you become tolerant to the drug. Or formation of an inhibitory metabolite, or equilibrium is reached very fast between arterial blood and the site of action versus venous blood, where we usually take concentrations in the site of action. Some examples are pseudoephedrine and cocaine. So the answer to this particular question is C, tolerance. All right, I'm going to finish with 3 questions on 491, questions 13, 14, 15. These have to do with specific issues related to therapeutic drug monitoring. So the first question is PL. PL is a 45-year-old male who has chronic renal failure, and he's receiving phenytoin 400 milligrams a day for a history of tonic-clonic seizures, and today's concentration is 13.6. His albumin is 4.2. So based on that concentration, what do you recommend to do with his dose? Make no changes, keep the total daily dose the same, but change the regimen from 400 a day to 200 BID, increase the dose for better seizure control, or decrease the dose to prevent toxicity. It's late and everyone's tired. All right, so let's go through these. I had a few souls with a few correct answers. Thank you. So I have some tables that go over just some specific issues with drugs that are commonly monitored therapeutically in clinical practice. Here are some anti-epileptic agents, phenytoin, carbamazepine, phenobarb, valproic acid. I talked about carbamazepine, how it's an autoinducer. That's an important characteristic. Phenytoin also is highly protein bound, so it's affected by renal failure, which decreases protein binding due to interaction between substances that go up. And also, it's also impacted by low albumin. And because of that, we have equations that we use in order to adjust phenytoin concentrations in renal failure patients, in patients with low albumin, and in patients with both renal function and low albumin. And you can see those equations listed there. And the easy thing about renal failure is if it's purely renal failure, if there's not low albumin as well, you simply double the concentration in order to do this particular correction. It's a little more complicated if you have low albumin. So the correct answer is D, you need to decrease the dose. Because in renal failure, we would double the concentration, 13.6, so that corrected, that's about 27. That's too high, so we would need to decrease the dose. Next is NR. NR is a 63-year-old male in renal insufficiency who's in AFib, and digoxin is going to start for rate control. So which of the following is correct? Keep the loading dose the same because of the renal insufficiency, but decrease the maintenance. Decrease loading, but keep the maintenance the same. Don't change either dose, or both doses should be changed. And I alluded to this previously. So we have some correct answers there. So again, information on digoxin and other drugs that aren't used anymore. But digoxin volume of distribution decreases in renal disease, and so watch out for that. And then digoxin can also be susceptible to drug interactions. I mentioned that with P-glycoprotein earlier. And because volume is decreased in renal disease and because clearance is decreased in renal disease, the correct answer is D. Both doses need to be changed because of those issues. And then finally, PP is a 34-year-old male with CP and UTIs, and tobramycin is started at 400 milligrams IV once daily, so once daily dosing is used. This high-dose extended interval regimen takes advantage of concentration-dependent killing, is more efficacious than standard dosing, does not require concentration monitoring, will not cause nephrotoxicity. Okay, and the correct answer, no dosing of aminoglycosides. You probably won't have to dose, but no, the issues related to high-dose extended interval. And the correct answer for this is A, it takes advantage of concentration-dependent killing by having very high concentrations because of the high doses. All right, I am done with time. If you have any questions, this is the last one, so I will be up here right by the stage, and you can come up here and ask me any questions. Thank you very much, and I'll see you bright and early tomorrow morning.